Solveig Hofvind is head of the Norwegian breast cancer screening program at Cancer Registry of Norway and a professor in radiography at the Arctic University of Norway. Hofvind is a radiographer by profession and training first, and a pioneer in establishing the breast cancer screening program in Norway, and we are very happy that you were able to come physically in person to this conference. That was very brave of you, and we really thank you for that. Solveig has impressively mentored 10 to 15 PhD students to successful dissertations and authored almost 200 publications listed in PubMed. Very impressive. She is the PI of the randomized multicenter TOBY trial that has been run in Bergen the last 4 years. I'm sure she will tell more about that. And published results from this study in Lancet Oncology recently and in Radiology several times. Solveig has had a long-term collaboration, I'm proud to say, with several researchers at MMIV, now continued with research within AI initiatives and AI tools for screening mammograms. She'll now give a talk entitled Breast Cancer Screening in Norway, Will AI Change the Landscape? Please, Solveig.
Thank you, Ingrid, for the nice introduction. Yes, breast cancer screening in Norway, and will AI change the landscape? It's a challenging task. I will, first of all, I want to ask, why should we use artificial intelligence or AI in Breast Screen Norway? Breast Screen Norway is the national cancer screening program. And my answer to that is that high image quality is a prerequisite for early detection of breast cancer. And today we are measuring the image quality subjectively. So we need something more to ensure the quality of the images. And we also know that it's lack of radiologists, and we also know that the radiologists are humans. So artificial intelligence could obviously be used for screen reading mammograms. And we also know that artificial intelligence is able to say something or to measure the tissue in the breast, which could be a predictor for breast cancer. So that possibility could also lead us into more personalized screening for the women. So first of all, I want to introduce you to the screening program in Norway, so my later slides will be easier to understand. In Norway, we invite about 620,000 women every 2 years for mammographic screening. Women aged 50 to 69 are targeted the screening program today. About 75% of the women attend. We screen at 23 stationary and 4 mobile units, and it's about 200 radiographers that are involved in the performance of the examinations. At 17 breast centers, we have the screening, interpretation, and recall assessment. And about 3.5% of the screened women are recalled for further assessment. It's radiologists at the screening at the breast centers that are reading the screening mammograms, and we have about 90 active radiologists in Breast Screen Norway today. As I said, the recall rate for further assessment is about 3.5% of the screen women, and we find about 6 cancers, screen-detected cancers, among 1,000 women screened. In addition, we also detect about 1.8 interval cancers per 1,000 women screened. Interval cancers are cancers that are detected between 2 screening rounds. So as you can see, it's a huge volume of examinations we are doing. So annually, we have about 250,000 screening examinations, which means we have 1 million mammograms and 1 million interpretations. So it means that the volume of mammograms is pretty big. And now a bit about image quality. And here you can see a mammogram. Pretty good, I would say, close to perfect. But here you also can see cancers that are detected close to the chest wall. And if it's not shown on the image, the radiologist cannot detect it either. So it's important. So we have done one study with artificial intelligence in Bergen, where we used AI system to analyze specific measures. For example, the nipple in profile. We know that the area around the nipple is difficult to interpret for the radiologist, so we need the nipple in profile in the images. So that was one of the criteria that we set and that we compared with the measurements done by the AI system and 2 groups of radiographers that reviewed the screening examination. And we found that the radiographers, they agreed more than the machine and the radiographers. So that's an interesting point of view, but if we are going to use artificial intelligence for image quality, we also need to know what are the machines pointing at and what do they accept and what do they don't accept. If not, we don't know what to change to improve the quality. We are also doing image quality study in North Norway. And it's a collaboration between the hospital in North Norway and Nordlandssykehuset. And we use a program where the radiographers can get the statistics on image quality criteria. And then we also want to use another system called Live, where the radiographers can get immediately feedback when they are doing the mammograms. They are getting red spots and green spots on different criteria, so they can consider whether they need to do a retake or not at the screening center. So the women do not need to come back for further images. And then we want to measure the image quality before and after the intervention with Live. So that's also that's an important part of the AI in my view. But the radiologists, they want to start using AI now. Why can't we start using AI in Breast Screen Norway now, yesterday? And it's many reasons for that. And in Breast Screen Norway, it's a system where we have 2 radiologists. We have independent double reading. Each radiologist score each breast with a score from 1 to 5. Radiologist A and radiologist B. And if one or both radiologists give a score 2 or higher, the case is discussed at consensus. And about 7% of the cases are discussed at consensus, while 93% have a score of 1 on both breasts by both radiologists and are considered negative. So, when they are discussed at consensus, they deselect about 50% of the cases. So among the 7% discussed at consensus, about 50% or 3.5% are called back for further assessment. Among those called back, we find a breast cancer in about 20%, 6 per 1,000 screened. So this is important to have in mind when we now are talking about how should we use AI in screen reading mammograms. Yeah, and yeah, because I ask, how should we use AI? And should we use it as an independent reader or as a support to the radiologist in single or in double reading? And should we use it as an arbitrator or only in the consensus? Should the radiologist have access to the score the AI system is doing or not? It's many aspects here that we do not have the correct answer to because we don't have the knowledge. So we need retrospective studies or studies on retrospective data to identify the system's sensitivity according to the radiologist, because all information about the radiologist score and the outcome of the screening examination is collected and stored at the Cancer Registry. And we have that information back to 1995, and it's especially interesting for all those cases that are screened with digital mammography, of course, and that happened from 2000 to 2010. So that's really a gold mine for us. And we also want to test to get knowledge about the effect in real life, prospective studies. But we really want to set up prospective studies based on the retrospective data. And we also need to estimate the cost effectiveness of implementing AI in Breast Screen Norway, because we can probably save a lot of time for the radiologist in screen reading, but if the recall rate increase, then the cost benefit is, it's not cost effective, so to say. So, we have one study now, machine learning in mammography, the MMIV study, where we want to develop an algorithm for interpretation of screening mammograms. And be aware that 99.4% of the screening examination are negative for breast cancer. And this is a study where Statistics Norway are developing the algorithm. And Cancer Registry, we are collaborating with 8 health trusts, and this study is based only on Siemens mammograms, and that's because we wanted to focus on one vendor in the first run, and then later on we will include more vendors. But you can see all the different collaborators here, and the study is supported by the Research Council. So we started up in 2018, and it has been a lot of work according to all the documentations, approvals, and agreements. Because when we are doing such studies, it's not that many that have done it before. So it's also a challenge for the lawyers and for all the decision takers to give us the approvals because of especially because of the GDPR, which is maybe understood a bit different for different people. But we are working hard, and we have received data actually from all centers. We received the last data from Helse Sør-Øst last month, and we are now trying to pseudonymize all the images. So when we have received the data, the Statistics Norway, they received the data, and they have already developed an algorithm that we are analyzing the data from. So we also have another study together with Statistics Norway, where we have included other vendors, but where we also want to take into consideration the screening mammograms prior, because you know that the women are coming back for several times, and it's the radiologist always use the prior mammograms for interpretation. So we also want to learn the machine to use the priors when they are considering and giving the mammograms an interpretation score. Yeah, this is with other health trusts where we also include GE, Hologic, and Philips. So when we get all these together, we will have about 1.3 million screening examinations multiplied by 4. So it's huge data sets we have, but be aware that it's only 6 cancers per 1,000 screened. So we really need all of them also. So, and yeah, when we have collected all these data, we also need to reuse the data because it's so much work, so much effort to get them into the cancer registry. And it seems easy to just run them through the machine learning systems and there we go. But it's also a lot of documentations, approvals, and agreements that need to be in place before we can touch the mammograms. But we managed to do it, and that's really interesting to see how this works. And this is the MIM data that I'm describing here, where we put them to Statistics Norway for developing an algorithm, but we also do retrospective analysis with CE-marked algorithms. So we do that in 2 different steps, and we have analyzed several of them now, and we are working very close with the clinicians to do this. And we are not only looking at the screen reading outcome, but also density and predictions of risk and image quality. So it's a multifactorial task here to get all the small things together. So giving a taste of what we find. Transpara is one of the vendors that we have an agreement with, a collaboration agreement with, and their system, they give all the examination a score from 1 to 10, and they divide them into about 10% in each group. As you can see here, this is real data from central Norway. And as you can see, it's about 10% in each. And the lowest score is among those with a score of 1, while the highest risk of breast cancer is among those with score of 10. So you can see the negative results, and you can also see the screen-detected cancers. And as you can see, it's 87% of the cancers have a score of 10. And that's pretty impressive, actually, because we have also looked at the radiologist interpretation score, and we know that between 20 and 25% of the screen-detected cancers, they are detected by only one of the 2 radiologists. It means that one of the 2 radiologists, they have given a score of 1. So the question is, what do we accept from the machine versus the radiologist? And can we expect a better performance of the machine compared to the radiologist? So that's an ethical issue, actually. If you look at the interval cancers, which is scored negative or it have a negative screening examination, we can see that 45% of the interval cancer actually had a score of 10. So that's also very interesting. And we also know that the interval cancers, they are much more aggressive. They are the killing cancer, so to say. So if we could detect more of the interval cancer in an earlier stage, that would be very, very beneficial for the women and for the society. So the results are promising. So we want to start up a study, a randomized controlled trial. We have the software installed in Ålesund and St. Olav, so the radiologist can train and understand how the machine is working. And we have a setup ready for the study and ethical approval, but there's still more work left to do before we can start. Most of it is related to the IT systems. We also have another study. The to-be study was mentioned, where we had a randomized control trial with standard digital mammography and digital breast tomosynthesis. And the detection rate was somewhat lower than we expected in the randomized control trial, but in the follow-up study 2 years, the screening round after, it was a much higher detection rate. And we want to go more into that and understand why was it like that. And we want to do a retrospective review of mammograms from screen-detected and interval cancers, both with internal radiologists at Haukeland, but also external radiologists from Germany, from the Netherlands, from Sweden, etc. And they will come to Haukeland in February to review these cases. And then, in collaboration with MMIV, we will do retrospective analysis with CE-marked algorithms to see whether the machine could find the cancers or not, and whether the cases was true cancers or whether they were missed. So that's really an important step to understand how we could improve the interpretation. Yeah, and we also have Stavanger that is working together with MMIV. And Hauke has extracted data from Stavanger, and we have just analyzed the data. And what I showed you for the other study was Siemens data. In Stavanger and Haugesund, Stavanger and Bergen, they have GE. And here we can find that 92% of the screen-detected cancer have a score of 10. So it's even better than the other one. However, it's a bit lower for the interval cancer, but still close to 60% are in the interpretation score 9 or 10. Another interesting finding here is the very, very small percent that have scores below 8 or lower. So I'm very excited about this and want to move fast further. So we have done a lot of studies on risk cancer among dismissed cases. As I said to you in the start of the presentation, the radiologists discussed at consensus, and about 50% of the cases discussed are dismissed. And we find a substantial higher risk of breast cancer among the dismissed cases. And we also find, as it said here, more among false positives cases. And we also have looked more into the field of 1 versus 2 radiologists. Yeah, so I don't want to say more about it, but I think that we have prepared us to look into the details of the AI and to understand more. So we should be prepared, I think. And the challenge now is the evaluation of the different strategies, or not actually the evaluation, but more how should we set up great prospective studies so we can get into and use the machine learning system as good as possible. Should it be read as a standalone system, as I said in the beginning, or should we use it only in the consensus? Because it's shown in several studies that if the radiologist has the interpretation score from the AI system available, they trust the AI system more than themselves. So after a while, they don't trust themselves at all. And we don't want to have radiologists that don't trust themselves in the Norwegian screening program. Yeah, and also the attitudes toward using AI is important. Yeah, to sum up, we have started, but documentation, application, approvals, etc., it's very demanding. I don't used to say such things because all researchers know that is the paperwork you have to do. But I think that this has been substantially more challenging than earlier because it's a new field for us as researchers, but also for the lawyers and for for the decision makers all over. So they actually don't know what they should answer, and we try to explain what we will do, but still it's challenging. We have several studies prior to startup and ongoing studies, but we are going on, and we have a close communication also with the PACS vendors and the breast centers, of course. And to run the prospective studies, we have substantial work with the IT system at the Cancer Registry. It's systems made in 1995, so they are old, but they are good, but they need really a new painting, brush up. More studies are needed, of course, both retrospective as well as prospectives, and results are needed to evaluate the effect before implementation. And here are some of the people we are working together with. Particularly Statistics Norway are important in developing the algorithm, and I really look forward to have our own algorithm in Breast Screen Norway. Thank you.
Thank you, Solveig. This was very inspirational talk, and I think it really shows how positioned you are, how well positioned we are in Norway, and you in particular with your team, to do AI studies in the context of screening. So I think this is, I think for the benefit of time, I think we have to limit it to a single question, and you have to give a short answer. There is one question here. Have you observed any significant differences in the results returned from the different vendors' system? It could be perhaps too early to give that answer, but a brief teaser?
We have agreement with 4 different vendors, but today we have only run data from one of them. But we are allowed to compare, so we will do that before summer, I hope.
Okay, so we have to wait in patience. Looking forward to that. So then, thanks. I think you have to answer more of this in the Discord afterwards, but let's go on to the next speaker for the benefit of time that you will introduce.
Thank you.